Thank you very much for joining us. It's really, it's great. It's such an important topic really for the Academic Primary Care Collaborative, and I'm sure that Lena has filled you in on what it involves. It's a pity that some of our other partners aren't here today, but hopefully we'll send them a video of the link and they can look at it. And I think maybe now is a good time for us all to do more formal introductions, just to let you know who we all are. I'll go first and then I'll go around my screen. So I'm Susan Smith, I'm a GP, and I'm the Professor of General Practice in the discipline of Public Health and Primary Care in the Institute of Population Health, which is part of the Trinity Medical School. And I just joined Trinity last February, and I've just taken, Noel was the chair of this group, and I've just taken over in the last few months. And it's a pleasure to have you here today. Noel, you're next up on my screen.
Hi, lovely to meet you, Reena. I'm Noel McCarthy, Professor of Population Health Medicine. Other than that, all the institutional things are the same as Susan just said, and I'm here a year longer than her. Okay. Trinity, thanks.
Sinead?
Hi, Reena, lovely to meet you. I'm Sinead, I'm the community rep put across from the PPN. I'm also on the Tallaght Community Council. I'm the inclusion officer there, which I look after all issues relating to children with disabilities, adults with disabilities, the elderly and mental health. I'm also a mother of a teenager with a disability.
Brilliant, thanks Sinead. Catherine?
Hi, I'm Catherine Darker. I'm Associate Professor in the discipline, same as Susan and Noel, but I've been here since 2007 for my sins. I'm a health psychologist by background training, so I'm really interested in kind of looking at the interface of psychology and physical health, but at population level. And I'm the Director of Postgraduate Teaching and Learning in the School of Medicine. And I think that's why I've been asked to chair the education subgroup. Yeah, great to have you here. Really interested in actually what you're going to say to us. Really interested. Thank you.
And Johanna?
Hi, Reena. It's lovely to be here. I'm really looking forward to your talk. I'm Johanna Ivers. I'm Associate Professor in Addiction, and I'm also the Associate Dean of Civic Engagement and Social Innovation for the college.
Great. And Imelda?
Hi, I'm Imelda Hanratty, and I'm also a community rep for the PPN, Public Participation Network. I work in Oncasan in Tallaght, which is an adult education centre and also has early years education facilities. Okay.
Brilliant. Okay, thanks. And Reena, we at the Trinity end, we would be involved in teaching undergraduate medical students who do primary care placements as well. And obviously, Catherine has mentioned the role that we would have in postgraduate teaching, and through the health equity course you've heard about, that involves teaching health professionals working in the catchment area around health equity. And we have links to the GP training scheme, which is co-located with our department, just so you have an idea about what our reach is in terms of teaching. So over to you. And Lena, you probably don't need to introduce yourself, do you?
No, I don't. well known to us all. So I want to begin by thanking you for even having me be part of your meeting. It was inspiring to hear the work that the APCC is doing, and to share that much of my discussion about equity in education with a focus on training will be not part of my talk today, but will be part of my talk to the faculty forum on Wednesday. And I think Lena can send you some details on that if your schedule allows. When Lena described the APCC to me, I thought about and sent me some wonderful materials about your work. I looked at them. I didn't know much about you. I feel more grateful now that I've been part of this discussion to hear the incredible work you're doing, but even from the written materials. And it left me with a question that I thought would be wonderful for us to think about and discuss in light of the work you're doing. And so just briefly, I am at Mount Sinai in New York, which, as I described, is a very large health system that sits on this fault line between the poorest community in the country and the richest community in the country, the Upper East Side of Manhattan and East Harlem. And our work has not been as deliberative and thoughtful as the work you are doing. I feel like the discussions you've had today are very rich and meaningful. And I think this is a journey that we're all taking. And so I'm happy to share a few slides of thoughts with you, more for discussion, and then to center the fact that we'll be talking a lot more about equity in education on Wednesday, primarily using as a driver for that conversation the Stand Up and Speak Out report that many of you may or may not have seen, that came from the Trinity Students for Equality and that Lena can send out. But I think that serves as a foundational document for the work, I think, that lies ahead as a university in the health sciences. So with that, and please stop me, hold on a second. Ooh. Wonder if, is it just the page down?
Yeah, or the arrow.
I tried. Oh.
It might just be. It should work the whole, like within the whole room. It's set to work in the whole room. I don't know.
Should I move?
It's working now, is it?
Oh, that's so interesting.
Fine, yeah, it's fine for us, please.
Okay, great. It's moving for you all, right?
Yeah.
All right, perfect. I think I'll have to hold this up. So, so just briefly, these are the materials I was looking at, that the APCC is acts as a focus for community-based collaborations to improve health and healthcare. That the work is facilitated through these 4 action areas: service delivery, advocacy, research, and education. And one of the things mentioned in the documents is this, one of the purposes of the APCC is to ensure that it engages extensively with the community and its stakeholders, really to bring their voices into the decision making. And Lena, may I ask you if there's a way to reset the, hold on. Sorry, we're still getting our, all right, into decision. So, my goodness, we really are a little sticky. Hold on, please. All right, and I think about the model that is clearly governs and underlies the work that you're doing as a care collaborative that is community influence, is this concept that we all know about in health and wellness, that, you know, healthcare really accounts for a very small percent of what influences health. We know that health behaviors, our physical lived environment, and socioeconomic factors contribute greatly to health outcomes. Almost 50% of outcomes are determined by socioeconomic factors and the physical environment. And to add to that, in addition to things like transportation and education and income, I think the discussion now around racism, bias, and structural bias is one that is really growing in terms of its link to health. I don't think I have to preach to your group about the concept behind that, but this idea that structural bias and structural discrimination, the concept of the policies and procedures and practices undergird everything we do, and it basically determines access to housing, to education, to healthful communities, to food that is accessible, healthy, and affordable, all have a very, very strong impact on health communities, health and healthcare, and particularly impact, as we know, minoritized populations. And so I think that this kind of framework, which really guides the work of a group like yours, really is, I think, at the front edge and leading edge of what we need to do in healthcare, because the focus of tertiary and quaternary care systems has been to deal with the downstream impacts of health outcomes, and yet we know that the biggest impacts can occur upstream. So the ideas that you've been talking about in the previous hour certainly have the chance at being the most impactful, because we're really dealing with the time, early childhood, housing, access, issues of bias, issues of disability, and really sort of working on upstream effects. Really, I think undermines why the work you're doing is so critical. So the question I had when I was looking through some of the materials is, how might this collaboration that the APCC has with the community, and how can it be considered deeply? How can it be operationalized? Because what usually happens in many engagements is that the community is brought in more superficially. They might not be part of decision making as it relates to the work of an organization. The interactions can tend to be more marginalized and tokenized, the idea of being present for certain things, being consulted for certain things, and sometimes even just being informed about plans or being asked to give feedback on very limited activities. And that's more typical of community engagement and collaboration between organizations and a community of need. And so I kept thinking about, well, what is the way the APCC is thinking about how it engages and how it collaborates, and how does it define that? So, meaningful community engagement, there are many, many definitions. One concept that really comes through is this idea of working very collaboratively with and through those who share concerns and challenges, that it includes partnerships and coalitions to really mobilize resources and influence systems of change. The CDC talks about how the relationship among partners really changes and thereby serves as a catalyst for changing those policies, programs, practices, the structural issues that we spoke about earlier. That there is a meaningful engagement really requires decision makers to defer to communities that they're working with. There's this concept of power sharing and equitable transformation, which are in some ways necessary elements to ensure sustainable change to improve health and healthcare. And then the idea also of working very closely with communities to really understand their preferences on degrees of engagement. For example, some communities may prefer to only provide input or be consulted at certain times, whereas others may prefer much more shared power and decision-making authority. So sometimes, as we know, our intention to engage does not always translate to effective engagement. And I think the question that sort of can guide much more how we define what community engagement is in a process like this is less whether we think that we are engaging with the community, but more whether the communities themselves really feel engaged with the work that is out there. And so I try to ask ourselves, are there any models out there that one might look at for meaningful community engagement in the construct of what the APCC does? Sorry, it almost makes me think we are on a different system. So here is a model that I would like to walk through, and then I will really want to go through the model in detail and then ask for your thoughts and questions and ideas. This is a model that comes from the National Academies of Medicine Leadership Consortium that brought together a project group to think about collaboration for value in science-driven health systems, to identify the concepts and metrics to best assess the extent, process, and impact of community engagement. And they had a wonderful wide variety of experts led by community leaders, practitioners, policy advisors, researchers, and scholars. And they began by thinking through a conceptual model to really illustrate the dynamic relationship between engagement and improved outcomes. And that was the sort of basis for their work. But why a new model? You know, I mean, we have other things out there. There are probably models we've used when we've applied for research funding. And this committee looked at a lot of models out there, and some of the critiques were that these previous models tend to focus on the processes of partnership, generally speaking, or connected engagement to factors influencing health, but very few models really associated engagement to outcomes or indicators or metrics. And the ones that did not embed the principles of diversity, equity, and health equity and inclusion really as core components of the characteristics and functionings. And I think given what I've heard from your group, given my interest in health equity and issues of inclusion, I think that sort of framework to meld that into a model is critical for community partnerships, engagement, outcomes. And so that drove this community to think through a new model. So when there was a discussion about what's important in a model for assessing meaningful community engagement, the first being, it was asked of this to think aspirationally, to not be sort of grounded in, well, we only have this metric available and we should use it. It was, what is really aspirational here? The first being allowing the community to make sure that the model essentially can be used in any community. This idea about, you know, it's not just geographic location that defines a community. There can be shared or common unifying traits or interests. So the model needed to be flexible. To consider health holistically, you have all spoken about that, but this idea that there is physical health, but there's a sense of well-being, there's mental health. So the definition of health would be holistic in this model. So these are the kind of key principles about what's important in the model. One is, you know, sort of allowing the community to see itself in or identify with the language definitions of concepts. And that is that the model needs to make sense to the community, usable by the community, to be written in a language that's familiar, and that the model and language should allow them to be able to see themselves in it, and the assets, the positive aspects of the community, which Catherine was talking about in her assessment, the idea of the assets of the community. And so that's important in a model for the community to see themselves as strengths-based. To embed equity throughout the model as the central focus for every decision pertaining to meaningful community engagement and thinking about person-centered care and healthcare. The third is this idea of presenting a wide range of outcome options for different stakeholders, because many are committed to assessing the impact of community engagement on health and healthcare policies and programs. The conceptual model needs to be relevant and usable by the range of stakeholders who are looking at it. And finally, the model needs to be able to communicate the dynamic and transformative nature of engagement, because it should place community and community engagement at the center, and that all that impact and influence should accelerate toward meaningful outcomes that ensure health equity as a transformative vehicle for health. So those four guiding principles essentially led to their development of the model that they then present. So here's my last slide. I'm going to actually walk you through this entire model, because this is the model called the ACE model, the Assessing Community Engagement Model. And it centers community engagement and core engagement principles. There are four propellers, if you will, that go from left to right, that focus on the meaningful domains and indicators of impact that are possible with community engagement. So in the center in green are the sort of community engagement, which is the linchpin and central focus of the model. It represents both the start and hub of all outcomes that will be assessed. And the core principles there identify the attributes that should be present in the process of community engagement to ensure that it is grounded in trust, designed for bi-directional influence. We know that as organizations and health systems and schools of learning, we benefit greatly from these models, but how is it bidirectional to the community? It's premised on culturally sensitive and humble approaches. And it includes things like equitable financing, shared governance, and relationships that continue beyond the project timeframe, that are authentic and enduring. And I love that it centers those core principles, because it allows us in the work that, for example, the APCC does, or organizations that are engaged in, to really center these principles and reflect on them in a frequent enough cycle to think if those core principles in the work they do are really being represented. So with those as the core principles, then you think about 4 broad categories that are shown in these, what they call propellers. They look a little bit like pedals, that are in these domains of measurable outcomes. And under each domain are the potential indicators, and it presents basically across all 4. There are about 19 indicators that are presented. So I'm going to begin with the one that's the palest blue, or the one that's almost white. Strengthened partnerships and alliances, and that's how participants emerge from the engagement with new or improved relational benefits that are carried forward. Diversity and inclusivity is really asking for this constant consideration of representation, inclusion, and the lived experiences of those who are engaged in the efforts. Partnerships and opportunities ensure that those who are engaged are fully benefiting from participation through mutually supportive relationships. And it's also that indicator that assesses whether participants have benefited from the bi-directional mentorship or through professional investment in this model. Now, acknowledgement, visibility, and recognition, which is the 3rd indicator under that same bullet, really reflect how community participants are seen and recognized as contributors, experts, and leaders. Developing sustained relationships require that the community, institution, and relevant disciplines maintain ongoing conversationals that are, again, not time limited or transactional. Mutual value, which is also listed there, ensures that the community is engaged in equitably benefiting from the partnership. And that's a hard one to operationalize, but an important one. Trust here is a core component of partnerships, because it really requires that we all show up authentically and transparently in order to build a long-lasting relationship. Shared power, which is really hard, reflects that the community participants are involved in leadership activities in terms of co-designing and developing the shared goals and visions and responsibilities of the organization. And structural supports for community engagement are the infrastructure that one needs to facilitate this engagement in a real way structurally. So that's this first domain. The second domain in the lighter blue is the concept of expanded knowledge, which really refers to the creation of new insights, resources, and evidence, and the formalization of respect, if you will, for existing legacies and culturally embedded ways of knowing that are unrecognized outside of the communities of origin. And this idea of using the lived experiences of the community to understand what their knowledge and awareness is, and using that as the guide and the driver. New curricular strategies, tools, or formal products of community engagement encapsulate new knowledge and evidence in a way that allows it to be disseminated, assessed, replicated, and scaled. Much of what we were speaking about when Catherine was talking about the model of assessment of the community, really this idea of using strategies and tools to get to know the community better, and then can be really used as a lever for change. Bi-directional learning, which is talked about there a lot, is when the community can collaborate to generate new knowledge, new stories, new evidence that reframes how the community is described and how the community is appreciated. And then community-ready information is an indicator that refers to the creation of actionable findings and recommendations that can be returned to the community in ways that they understand, value, and can use. And I think the project, again, that Catherine was talking about is one of those that really feels like something that not only can benefit a lot of other communities within the university space, but how does the community use that information? And how do they have that information at hand in ways that they can value and use themselves? The third pedal there, the third propel there is improved health and healthcare programs and policies. This is often the driver in collaborative healthcare community-based engagement projects that we have in the field, as will be familiar to you. But this is to really have solutions that are fit for purpose and that are embraced and championed by those who it's designed to serve. So community-aligned solutions come from and speak to the priorities of the community. Does the community see the driver for every effort that is occurring here? Or is it more coming from, in some ways, maybe an intellectual curiosity or a policy-driven curiosity that often can guide it when universities build these relationships? Actionable, implemented, and recognized solutions are indicators of success. The results need to be visible within and across the community. And then sustained solutions, which refers to the new interventions, the programs and policies that again extend past an initial period of support. And this particular propeller is the one, I have to say, coming from healthcare, feels most familiar to me. I think the other two are really allow me really to think through more broader and more community-centered ways of assessing engagement. The fourth propeller is this idea of thriving communities. And this idea that as motion accelerates through the strengthened partnerships and alliances, through expanded knowledge, through the improved healthcare programs and policies, you assess the impact of community engagement moving into the concept of a thriving community. The 5 indicators that suggest this are the physical and mental health, which is the whole person definition of health reflected in a community's physical and mental health status and well-being. The community capacity and connectivity, speaking to the growth in skills and capacity of the community, both as individual members and as a whole, to act on their behalf, to act on their own behalf. Community power, a wonderful concept, which is a paradigm shift that assures processes and procedures are favored, initiated, and guided by the community. Community resiliency, another conversation that's very important to have. The overall strength of the community and its internal capacity to self-manage, and reflects the ability of a community to recognize and mount a locally relevant response to new adversities and to engage and advance in culturally effective solutions to strengthen the community over time. And then life quality and well-being, the improvement to drivers of health in the community, education in the space, economics, racial justice, and the built environment. So those were the 4 big propellers, and around it, you see this broad bucket of the drivers of health, the drivers of change in health and healthcare systems, and the social, political, racial, economic, historical context, right, in which we all live, the sort of air we breathe in, the space we breathe in. And many of these align with the social and structural determinants of health that, as we know, expand far beyond traditional factors. The drivers of health really referring to factors that ultimately influence and impact well-being. The drivers of change in health and healthcare are the key levers that influence stakeholder action, including data-driven, evidence-based policies and practices, including things like grassroots organizing, regulations, and financial incentives, of course. And then the relevant social, political, environmental context, which underpins, if you will, all community engagement efforts. Because the sort of context in which this all occurs allows, I think, the partnership between an organization and the community to be conscious of and aware of what's going on in the environment in order to drive the efforts that the organization is conducting. So that is my last slide, and I can't see you all, so we're going to minimize so that we can have a conversation. For me to think through and understand, does a model like this resonate? How has the APCC thought about assessing the impact of its community engagement? To hear your questions and thoughts, and then I will keep quiet so that we can all chat.
Thanks so much, Reena. That was it's really interesting. And you know, if anyone has any comments or questions, if they want to, I think there's so few of us, you can probably just stick your actual hand up or just unmute yourself.
That was really amazing, Reena, and I love a model because it kind of helps to make sense things that sometimes can be abstract. I really liked what you said about the fact that it's important to get the view from the community about what they felt the engagement achieved for them. And I'm kind of wondering the process of how you do that. You know, the kind of classics of a survey, a focus group, you know, noting numbers, attending events, that kind of thing, are things that kind of spring to my mind, but perhaps there's other mechanisms that you're aware of that you could talk to.
That's great. That's a great question. I'm also curious to hear others' thoughts on it. I think you're right. I think sometimes even our survey systems and methods can feel so burdensome to a community because they just feel like we're constantly surveying them. You know, I don't know if the one approach might be where there are community leaders who are participating, where there's a process where through community discussions, they facilitate that information back to us in their various spheres and lived communities. So for example, if there is a committee around housing, you know, how are they bringing back information to us around the impact of the work we're doing in that regard? Or through health equity promotion, are there people involved in their neighborhoods and communities or community organizations that can bring information back to us? Because sometimes I feel what also happens is the people who might be represented on our boards or our, you know, structures that exist for this partnership are giving a lot of time already. And so saying to folks, you know, go out and collect more information might be very burdensome. But are there groups that they're already part of that they could then channel information back? Other thoughts? Are there people who have other ideas for how we might assess? Catherine's is a great question.
Reena, can I ask you a question? When you refer to bringing information back to us, who's the us you're talking about?
I think in this case, I was thinking more about the APCC leadership, like this kind of, and the other people who aren't here, but this idea that there's a group that's spending so much time thinking through the programming and models, you know, in so many ways, even thinking about funding, the structural supports to this work were really incredible because you can't do this alone, and we need funding to embed this in the future so that it doesn't drop off as soon as the research question is finished being asked.
But Reena, I suppose that's why the bi-directional and co-creation piece is so important that you talked about in terms of the process and the outcomes, that it's only if we truly engage in those practices that, you know, it really is a collaboration of sorts. And that's why, as you say, we have the community reps on. One thing I was interested in was around the equitable funding and whether or not, you know, there's been in your experience that, you know, there's a need to build in monies or ways to reimburse, as you say, other community representatives who can come in for part of the work so that they are being paid or reimbursed, and that's something we're placing a value on. I'd love to hear your thoughts or experience around that stuff.
That's a very, very good question, Joanna, because we have faced that in our community engagement work, where there have been individuals who are funded and supported to be on a small group, a leadership group. But then there are individuals in the community doing a significant amount of work that relates either to operationalization or through work that is related to the programming. And we have had, as an organization, a reckoning over that, because many of our community partners went through the governance structure of the city, which is in New York or in the US, the community boards, which are not health professions related, and raised concerns about that, about the inequities in that. And the health system had to come up with a definition of participation, a definition of adequate compensation, a definition of what it to participate when you have the structural barriers that communities have, and to be extraordinarily transparent about opportunities so that people could apply for them within the community. So oftentimes I just think of the research arm, it would be a community health worker who would then connect with a few individuals in the community and offer the opportunity. And that was felt not to be equitable because the community health worker would know who they were reaching out to, and their network became the peep set of people. And so one of the things we've had to do is have more transparency in how we're soliciting community partnership, engagement from people in the community. What is the process of selection? We actually transferred the process of selection away from the health system to have members of the community select the individuals who were going to conduct it based on a set of 2 tasks that needed to be conducted, which was hard for the health system because the expectation often was that the health system would decide who gets to do what, and then to have a very transparent process of payment. And it took a lot. It took the health system moving far away from its comfort zone, but I will say that the work that has happened in terms of the true partnership in community engagement and the accountability for it was transformed and saw tremendous benefits during COVID, because all of a sudden we needed a much stronger sense of community support in order to engage with the disparities that we were seeing. And we could not have done it had we barreled through the system the way we had before.
Thank you so much for that. And my next question is then, do you have protocols around that, and would you be willing to share them?
Sure, I can definitely ask for what we have. They're all centered, of course, as well in the US context, but absolutely.
Thank you.
And could I just go even a bit deeper on that, Reena, around do you have a fund that the health system has earmarked to support this remuneration, or do you have is it a charitable fund, or how do you actually financially support it?
It's all funded, Susan, through the research driver.
Research driver, okay.
It's all funded through the research driver, which is that, the institution, and I'm so curious to hear from you all in terms of mentioning the research work, and Noel was talking about it. The community, it is not lost on our community and community partners that the university gets millions of dollars for its community-based research efforts through grant support, millions. Only recently has the work centered around health equity as a research, as a funded research stream, which is now through the National Institutes of Health been very, very well funded. But in the past it was embedded into grants and therefore was much less transparent. Now is much more visible. And I think the community, especially the community leaders who are part of our health equity funded research and our community-based participatory research, it is not lost. That is not lost on people.
Mm-hmm. I think in Ireland we have over the last, say, 4 or 5 years, we have developed an incredibly strong patient and public involvement in research arm through our national research funders. So if there was a call or an application that had a health equity focus, you could put in substantial budget to support this activity. But of course, it's not sustainable once the research is done. That's the real challenge is how, and they're working out all the budgets, all the appropriate remuneration for that activity. But as you say, it's very much focused around the actual research.
Susan, to your point, one of the most interesting things that happened at our system was the community wanting to be much more involved, and rightfully so, in the questions being asked around research, as opposed to being told, this is the project that got funded, we are now looking for X, Y, or Z. It was, what are the questions that are important? And I liked that in this model, this idea of the co-creation, the concept of what's important to a community using the assets-based approach to strengthen an approach to dealing with a challenge or vulnerability. Because in many ways, it makes sound sense that that those kind of interventions will have more lasting impact when they are co-created, as opposed to this is an intellectual question for me from where I sit.
Yeah.
And so I think one of the benefits of some of we had very strong models that were about how the community in East Harlem, we have very, very high prevalence rates of extremely poorly controlled diabetes, very, very high. And the initial models, all these models of sort of sitting in the ivory tower and talking about how we would bring which intervention forward. And it was the strongest and most impactful work came from the community designing, to Catherine's area of interest, this incredibly cool educationally focused project with very young children around more healthful eating, but really focused on sugar. And I remember as a trainee in medicine, as a resident in medicine, we did the teaching in the primary school. And one of the questions was to show young children a bottle of Coca-Cola and asking them how much sugar they thought they had. And we took these bags of sugar, we put out like 2 and 3 tablespoons. And then when we took out the 39 spoons of sugar and made it into a big pile, you know, I mean, that came from the community, this idea of what do we eat and drink and what's the upstream intervention. And it was unbelievable because it had an impact on what was put in those schools and the machines. It had an impact on the children going home and taking this information home. And so that was one of the first models of this co-creation, because initially it had been all of us going, the researchers going in there with a completely similar hypothesis, but a different plan. And so I feel like the long-lasting things are really
one thing that as you're speaking there, I was thinking about, we have in this country we run what's called citizen assemblies, and they are what they sound like, and they've been engaged in different areas that have been very topical, some controversial, say around termination of pregnancy. There's been a recent one around climate change and biodiversity. Just as you were speaking there, Reena, I was thinking, God, wouldn't it be cool to have a citizens research assembly where citizens are actually starting to generate research questions from a kind of a bottom-up real world perspective about things that they think actually scientists and clinicians, you know, need to get involved in. That could be a way of taking, again, a model that is running, I think, to quite good effect from what I've read about the Citizens Assembly, but focusing on research.
Wow, that would be so interesting.
Yeah, there is a model of that through the PPI Ignite national program, where they do bring together all of the PPI programs. But I suppose it's that transitioning that applies to any kind of research, but we're kind of focused a little bit on health. You know, the discussion we're having is around health equity and what's the overlap between patient and public involvement generally, and then the much harder to reach groups that you might really want to co-create interventions with, who experience all sorts of different structural inequalities. I'm kind of conscious, Sinead or Imelda, would you like to come in? Too much time left, so it's really important to get your, even if it's just a reaction to what Reena is saying.
No,
yeah. I'm sorry.
I suppose the last bit of the thing that they did with the bottle of Coke, and I've been involved in a fitness thing before where we actually brought in stuff like that and spoke about the difference of white bread, and we got the kids to roll it up. And when you roll the brown bread up, it wouldn't even roll up. So we were kind of showing them that breaks down your body. But when you rolled the white bread up and you threw it against the wall, it never even broke. So I've been involved in lots of that about health and fitness for children and adults. So it was very good to hear that there is research, and it could be something that we as a nation should really start on a ground level, start to do within schools and that. I think the other main thing I could hear and feel throughout the whole presentation was the word inclusion in all aspects. And I thought that was very good, but also it is cemented, I think, within APCC as well, that we are very inclusive in all the approaches we're taking throughout the community and through academic as well. So it was good to see our model stands to that as well, from looking at what Reena was putting up.
That's wonderful.
And Imelda?
Yeah, just around, like, I suppose, community and getting more people aware and involved is kind of strikes with me. And Sinead would know, we're like community reps with the Public Participation Network, and they've been doing a lot of work with you know, South Dublin County Council as the Have Your Say programme. So there's actually a meeting this week where we'll be reporting back, myself and Sinead. But I think there is a lot of, I'm going to say effort, but there is a lot of work going on at the moment in trying to get the public involved, which is hard enough to get people involved. But I do think it's something that has to be worked at all the time and looked at different ways, because we always say communities, but it always comes back to, like, who is the community? You know, is it made up of all different communities, different people, different backgrounds? So it's just having it out there all the time is kind of where I'm at.
Imelda, that's such a great, oh, sorry, go ahead, Sinead, sorry.
No, I think Imelda is right. It's about, when you speak about communities and when you're doing work, it's really what you want to get back. And then I think it can be broken down more into subject matter, really, or what, if you're talking to people within the community, everyone has something different that they want to bring. So sometimes it's very hard when you're speaking about health or you're speaking about anything within education. It's your own experiences, and it's about how to channel that then. How, when we get that information, how we channel that in the correct way. So I think that sometimes it's hard and it can fall down, and it's very hard to keep that going. And I find that's what happens within our community at times. We have great people working, but it just falls. It doesn't get, it gets so far, but doesn't be able to come out to fruition at many times. And then those people can lose heart. So it is something that I know that the PPN are looking at, and South Dublin County Council are looking at, as to how to find these community people and to keep this moving forward now, and the Have Your Say programme keep going forward. So
they're both great points. One of the things I was thinking, two things I was thinking about. One is that in the US, one of the things we did in our, and that actually came through sort of a governmental non-research agenda, with this idea of what's called participatory budgeting. And so it was an interesting point, this idea that communities would get together, they would need to be representatives, to Imelda's point, that a community is not just sort of one group. How does one bring in representation from different groups? And representation from point of inclusivity, not tokenism. So not just one of X and one of Y, but how do you bring in people to that space? A discussion of the most interesting present topical areas from each person, and then a process of facilitated decision-making around the top priorities, around consensus, that would then drive the process for that period forward. And it was wonderful because these are extremely diverse communities, as you can imagine, in parts of the city. And they did that in many, many areas. And that would drive, in that case, it was driving the city council for its budgetary process around work that the council was going to do in that area. And it was so powerful because all of a sudden it was that there were people in the room, the people were well represented, but there was a process of facilitated discussion to come to consensus on the projects that would be moved forward in that time period. And that might be one way of doing it, where you're right, to Sinead and Imelda's point. One is who's there, and then how do you do it in such a way that's meaningful so you don't lose people at the end of it.
yeah.
No one might, and nothing happened, I'm out of this work. I've got 20 other things that are really topical for me right now in my life.
And I suppose, is there, like, I wonder, does the PPN do some of that behind the scenes? Like, we as a group, as the APCC, are kind of dependent on the PPN to provide our community representatives, or a link to that. Like, we might not have capacity to do that type of work for the whole community to source community reps. But something that we've encountered, and Reena mentioned a study, a survey of our that our students, a project that our students led on racism and bias and inequity in the health sciences programs here in Trinity. And one of the things that emerged was representation on the Students' Union and the lack of diversity there on the Students' Union. So even though they have a very well-established mechanism for trawling the students for reps every year and encouraging engagement, the diversity isn't there because it was reported back that a lot of the either international students or the not white Irish EU students basically said, well, sure, that's not for us, we don't do that. And if somebody was elected from an international student body they would be considered to only represent the international students and not all students in the class. So there's this problem that's existing within the representation at a student level, and I am presuming that same problem is existing across all of the communities as well, because when we went out into the community, we went to Imelda's workplace where we had a group of after school kids. There was huge ethnic diversity in the class, in those group settings out there, you know, and it's how to tap into that diversity is a big question, I suppose. Yeah.
Right, and then this feeling of even if I participate, what would happen, or what would, you know, and some of it might be that, at least on this setting, the student setting is a little harder, but I think in this kind of work is over sampling, over representation of those who are minoritized can actually be of tremendous benefit, because then in a room there's more confidence to speak, you know, even beyond the number. And so even challenging our systems of how many need to be in the room, and we only allow 8, we might have to be more expansive than that. And frequent feedback loops with those members, you know, how is this going for you? Not in the space of the privileged, but how is this going? And do you feel like you have a voice? And how can we enhance your participation? That type feedback loop, I think, could be very, very helpful, especially when, as you point out, that on the ground you see that tremendous diversity, but then you're not seeing that in the representation.
Yeah, exactly.
And can I just say, I think, Catherine, not to give you another job, but you might be onto something. Last year, the SFI ran a campaign creating our future, where I was one of the assessors, but it was basically a call to the public about what kind of research themes they want researchers to take on, and what kind of areas they'd like people to look at. And I don't know whether, you know, it was matched according to assessor's background, but I don't think it was. But the good news story was that there was a huge public appetite for health equity type studies. So I think the next level to that would be probably to kind of engage people. And I know that there's a report on SFI, or I can try and track it down, just that looked at synthesizing some of those things. So.
Wow.
Yeah.
I know Catherine does not need more work, but my gosh.
But I think that
sure
within it, I think within APCC, it will be really helpful for us to, I mean, even everything we've discussed today could have more inclusion at its heart. Like even the books we choose for book packs, you know,
Yes.
is there representation? And then the ideas of supporting. Most of you, well, many of you, really, you may not be familiar with the James Lind Alliance, which is a very strong patient engagement process in the UK to drive research priorities. And we're doing one of those through the Primary Care Trials Network. It's a very structured approach to making sure that questions are decided by the participants in the research rather than the healthcare professionals. But I think that we could certainly we can learn a lot from that model that you've presented in the framework. The one last thing, I know we're getting a bit tight for time, is I think it would be really useful if you had any papers on the outcomes you've used to evaluate your activities. That would be really helpful for us, because really we haven't done any evaluation formally. And it would be great to be able to kind of use your experience on what both, I mean, Catherine has asked about the methods, but I think the outcomes would be really interesting. What's a good outcome of an effective non-tokenistic engagement?
And to your point, Susan, one of the things this National Academies panel did, and the citation is on the side, is that they are, I think, in the process now of even bringing another consensus conference together. Because at the end of this paper, which is really quite remarkable to read, they talk about the fact that now operationalizing the outcomes and metrics within these particular domains is going to be very, very helpful, globally, as work continues to, be increased in community engaged work.
Okay. Reena, would it be okay when Lena's circulating the minutes, if we could also have your slides with the links to those documents? That would be really helpful. Brilliant. I'm just kind of conscious a little bit of time. Does anyone have any last questions for Reena? And then we just have to cover any other business on the next date. Well, I think we have that already, so we're okay.